Assalamualaikum warahmatullahi wabarakatuh. I am Nasiruddin bin Wahab, student semester 9, Bachelor of Medical and Health Science, Open University Malaysia, Kuching Learning Center. This is presentation about subject NBCP 2626, Clinical Practice, Trauma and Emergency Care. My presentation case is status epilepticus. This is the identification data for the patient. The patient is 38 years old, male, Iban, Christian, working as a driver at Camp Penison Army, married, and date of admission of patient is 5 of November 2020, and then information from his wife. Chief complaint of the patient is recurrent fitting for 4 times in a day witnessed by the colleague during at work. So the history of presented illness is he was previous well until he suddenly had fit for 4 times at 11, 11:30, 12 noon and 12:30 noon. The fit characterized with uprolling eyeballs, stiffness of upper and lower limb, and drooling of saliva coming out from his mouth. The fitting is associated with urinary and bowel incontinence. The patient is not respond to surrounding during fitting. Fitting lasts for 2 minutes each, and then post-ictical drowsiness and not regain full consciousness in between fit. On further history, he has no fever, no history of fall of trauma, no loss of stool or vomiting, no abdominal pain, and no complaint headache or giddy before the fitting. For the systemic review, we start with cardiorespiratory system. The patient have no history of cough, no running nose, no shortness of breath, no chest pain, and no palpitation. For genitourinary system is no history of any pain or difficult in passing out of urine. And then gastrointestinal system with no other significant history. This patient past medical and surgical history is this patient have a hypertension under the sub follow-up medication, and then have a gallstone. Drug history of patient is tablet amlodipine for 10 mg OD for hypertension medication, and then but the patient is not compliant with medication, deny any traditional medication. Family, Mr. MM married with 1 child. He is the first child from 4 siblings, and all of them are healthy. There is no similar case like him happened before to any of his family relative. His mother also have a hypertensive. This is a family history. Mr. M, 38 years old, married with his wife, 36 years old, and have a child 6 years old. See. This is social history of the patient. The patient have smoking and drinking alcohol since 20 years ago. Smoke for 20 sticks of cigarette per day. Very heavy smoker. And then he also drink alcohol 4 to 5 times per week. He have no history of recent traveling to jungle or swimming to the river. Deny any history cat or dog bite. For physical examination, we do the general examination. The adult male patient with medium body build. He was restless, no cooperative and aggressive, tied on the bed on his four limbs. This is better sign of the patient during arrival to emergency trauma department. The GCS, Glasgow Coma Scale, E4, V4 and M5. So total GCS for patient is 13/15, and then pupil for this patient 2 mm left side and 2 mm at the right side. Blood pressure during arrival is very high, 210/131, and then with pulse rate is 137 per minute, regular rhythm and normal volume, and temperature is 37 degrees Celsius. The hand is no pallor, and head and neck is drooling of saliva. Central venous system is normal, and respiratory is normal, and abdomen is also normal. On central nervous system examination, he is very aggressive, lying on bed with both upper and lower limb tied. The power of both upper and lower limb is normal. Babinski reflex is also normal. So no neck stiffness was noticed. The summary for this patient is 38 years old Iban gentleman working as driver with hypertension was bring to emergency in a day prior to admission associated with postical drowsiness and not regain full consciousness in between feet. Physical examination aggressive with GCS 13/15, blood pressure 210/131, heart rate 137, tachycardia, and smoking and taking alcohol. So the diagnosis is status epilepticus secondary to inquiry the causes. Provisional diagnosis is one of the provisional diagnosis is post-stroke epilepsy. Point for recurrent fitting, hypertension on tablet amlodipine, not compliant with medication. Patient also smoker and drink alcohol with high blood pressure during on arrival. And then differential diagnosis of this patient is intracranial bleed. Point for recurrent of fitting, male, hypertension, not compliant with medication, smoker and drink alcohol also, with high blood pressure during arrival. So point again is this patient is not complain any headache or giddiness before fitting. Another differential diagnosis is intracranial infection like meningitis, meningoencephalitis. Point for recurrent of fitting, not fully conscious and aggressive. And then the total white cell count is increased. Point against patient, no history of fever, no neck pain, no vomiting, no headache, and no stiffness. And then the Babinski sign for this patient is normal. Brain neoplasm. Point for recurrent of fitting, patient well before the fitting episode that may happen. Normal blood electrolyte result. However, the patient is also differential diagnosis for this patient is also alcohol withdrawal. Point for recurrent of fitting because of taking the alcohol frequent 4 to 5 times per week. So the liver enzyme had increased. The patient aggressive behavior and not fully conscious after fit during on arrival. For metabolic disturbance, for point for recurrent fitting, head taking alcohol frequent that may cause electrolyte imbalance like hypoglycemia and electrolyte imbalance due to not taking proper food. Points again, patients do not have vomiting or loose stool that may cause more electrolyte loss. Then the other differential diagnosis is rabies. Point for rabies is patient had fitting and aggressive behavior. At the same time, the patient stay in Kuching, which is Kuching still has rabies case. History of animal bite, unable to exclude as patient unconscious. For the acute management, patient had arrived at emergency department with aggressive behavior with GCS E4, V4, M5 with high blood pressure 210 over 131, heart rate is 137, sinus tachycardia. Patient had been restrained on the bed over 4 limbs with clot. This patient also we give with high flow mask, full oxygen 15 liter per minute. So the medication what we give is anti-epileptic, IV midazolam 5 mg and IV diazepam 5 mg, and then another midazolam given 5 mg. At the same time, we give normal saline for maintenance, and then after complete this medication to this patient, the blood pressure is reduced to 140 over 90 and pulse rate is 130 beat per minute. At the same time, we take the blood for investigation. This patient is also intubated due to GCS is not improving. We intubate this patient with ETT size is 7.5 anchor at 31 cm with IV petanil 100 microgram, IV midazolam 10 mg and IV roconium 50 mg. So we also take the ABG, atrial blood gases, done doing ECG, electrocardiogram, and then send this patient for chest x-ray and CT brain. This is the blood result investigation result. This is for full blood count. The hemoglobin show is 16.7 normal, and then the total white cell count is high 19,800. Platelet is 473,000. Differential count is lymphocyte is 58, and then neutrophil is 30.5. So we do also random blood sugar 8.9 millimole. For blood urea serum electrolyte, the result is here: sodium, and then potassium chloride and urea show the normal. Calcium, magnesium and phosphate also normal. And then we do also liver function test. Total bilirubin 12, AST and ALT 40 and 60 high, show the high result, and then albumin 26, and then alkaline phosphate ALP 50. This is a result for atrial blood gases. pH is 7.352, PO2 is 121.4, PCO2 43, CHCO3 23.3, BE 2.3, SO2 98.4. Okay, this is the result for attributable gases. Let me show about the ECG for this patient during at emergency trauma department. The ECG show patient sinus tachycardia. This is the patient chest x-ray we have done. What we see in here for episupine result is the heart is like cardiomegaly, and then I see the ETT is in place. The left and right side lung normal, no abnormality for the lungs. Okay, all right, we go for other show. This is show about the CT brain. CT brain show ill. Ill mean define hypodensities at right frontal, right corona, and bilateral external capsule. No intracranial bleed seen. No hydrocephalus. No middle line shift. Vessel cistern and cerebral sulci preserved. Mucosal thickening and bilateral ethmoidal sinus. Others paranasal sinus and mastoid A cells are clear. No skull vault lesion. So the summary for CT brain is multifocal recent infarct. All right. So management intensive for the patient is patient had been referred to medical team for further management and investigation. After investigation done by emergency department, this patient sent to ICU for intensive monitoring and care. All right. So the intervention to the patient is what's for lumbar puncture, EEG, electroencephalogram, toxicology screening, and then for the medication is anti-epileptic medication. Treat the cause of fitting after diagnosis had been concluded. So the conclusion is status epilepticus is medical emergency. Proper early management in emergency department help in reduce morbidity and mortality. Different diagnosis must be excluded as early as possible with proper investigation. Very emergency medical. Okay, thank you from me, Nasiruddin bin Wahab. Again, student semester 9, Bachelor of Medical and Health Science, Open University Malaysia, and then from Kuching Learning Center. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.